has been really involved in a lot of troubleshooting and working collaboratively with their patients to make telehealth work however they need it to work, including, you know, moms who drop their kids off at school and then sit in their cars and do telehealth over FaceTime because it's the only private place that they can, you know, that they can do a session and in the time that they have between getting their kids to school and needing to go to work. She's had a lot of experience figuring out what to do with things like CBT worksheets and, you know, making sure that people have just as rich of an experience in using evidence-based psychotherapies, whether they're doing it remotely or in person. So she'll be joining us in 4:30. She's got to wrap up another commitment. So as you can see, we have a great group of panelists with a range of experiences. And so we're really thrilled that they could join us. And Dr. Khan is joining us from New York, where we're a few hours later. So I want to thank them, and I want to go ahead and give Dr. Mathur and then Dr. Khan an opportunity to just say a little bit more about challenges and opportunities at this particular time when most of the nation is converting to telehealth for meeting the mental health needs of their clinical populations that they serve. So first, let me just give each of them a chance to comment on any challenges, opportunities, or just other things that they think we should keep in mind. And then we're going to move to some of the questions we have for the panelists. So Dr. Mathur, why don't we start with you?
Yeah, so I think we're in unprecedented times here. There's a lot of anxiety, a lot of fear, unpredictability, both among providers and patients. And I think the one thing as clinicians that we really need to watch out for is thinking about the surge that lies ahead for us with regards to the increase in mental health issues. So I'm already seeing a number of patients who are destabilizing. We're getting an increase in the number of patients calling our crisis line. I work at the Veterans Center, so there's an increase in PTSD symptoms. So I think, you know, one thing we really have to keep in mind is that we're breeding a generation of trauma here, whether it's people directly affected by coronavirus, patients and their families, or frontline healthcare workers, ER doctors, ICU doctors, people who already have mental health conditions that are, you know, getting worse in isolation or in quarantine. You know, an impending financial crisis that may increase these risk factors. So we really need to start thinking about that. And I think the one thing that we need to focus on right now is decreasing the barriers to access to care. And telehealth is a huge modality to really overcome that. We can access patients, as you mentioned, in their car, you know, as they're waiting for their kids, or at home when normally they wouldn't be able to leave their work to make an appointment. So I think really right now what we want to look at is how we can increase access to these patients, as well as how we can look into preventative medicine to avoid this drastic surge in mental health issues in the future.
Okay, thank you very much. Dr. Khan, would you like to just say a few words before we launch into the questions?
Sure, absolutely. And so I'm in New York City right now, and it's really great to join everyone at Stanford. So thanks for the invite. So it's 7 p.m. here in New York City, and every night at 7 p.m. the entire city cheers for our frontline workers and for all of our essential workers. So I don't know if they're still doing that, but I can quickly take a look. I had muted earlier, but let's see if they're still. I think, yeah, there's a couple. I don't know if you can hear it, but just to kind of give you a sense of where we are in the city. And I co-chair the American Academy of Child and Adolescent Psychiatry Telepsychiatry Committee, and I'm on the APA Telepsychiatry Committee as well. So we've been working with members who've had questions recently as they're implementing telehealth, whether it's a private practitioner, hospital system, a group practice, kind of considering the lead. Sorry, I think I had just muted. So at NYU Langone, we have a separate Department of Child and Adolescent Psychiatry that's separate from the Adult Psychiatry Department. Our department, we have 100 faculty members and about 30 trainees, and all of our faculty members are provisioned to be able to do telemedicine through Epic, which is our electronic medical record. So that's been very helpful as we transitioned our practice to almost 100% tele at this point, whereas before we were doing about 20% televisits. Across NYU Langone, we significantly expanded our telehealth services as well. So now this week we're up to 6,000 visits a day across the institution, including virtual urgent care, which has been immensely helpful through the current crisis.
I think, Shannon, you're on mute.
Okay, is this better?
Yep.
Okay, great. It's interesting. I'm on my phone just to make sure I've got a better connection, and apparently I have to unmute both. So thank you both very much. I want to, our hope is to spend a lot of time talking about opportunities, innovation, ways to really optimize clinical care over telehealth. But first, I want to acknowledge that, you know, these systems across the country have been rapidly converting to telepsychiatry, telepsychology, and there have been challenges along the way. At Stanford, we're, you know, a couple of weeks in to folks really moving more to telehealth. And so I was wondering if each of you could comment on what some of the challenges are in converting to telehealth, and what types of things people need to keep in mind, or tips for overcoming some of the most common pitfalls. Dr. Mathur, could we start with you, and then we'll move to Dr. Khan?
Yeah, so my goal as the director of virtual behavioral healthcare was by the end of the year to have our whole system converted to telehealth. So my job is done. In the last 3 weeks, I've been able to accomplish that. But you know, clearly there's a lot of challenges with regards to getting equipment to providers, making sure our patients have the correct equipment, making sure the connection issues are, you know, the bandwidth is okay for that the server isn't getting overloaded. And unfortunately, we faced all those issues with regards to implementing telehealth. But I would say for the most part, you know, 80% of our system is now working. We're able to really deliver telehealth appointments. I think the one important piece that everyone really needs to think about is the safety part of it. You know, what happens if there is an emergency for patients? Which patients may not be appropriate for telehealth, but we have no option at this point. You know, high risk patients, what are we doing? What are the safety measures in place? And I think that's one area that I really tried to stress in our system with our providers, especially for mental health issues. And I think that's one area I'd like to stress for other systems or for other individual practitioners really looking, you know, we're all pushing for telehealth, but what happens? What's your plan if something happens to a patient who's not physically in your office or who's not in your county? Do you know the appropriate resources to call and to kind of get in place? So I think that's the most important aspect. And I think, you know, otherwise it's which platform you're using. If you're outside of a healthcare system, you know, whether it's Zoom or something else, figuring out which system works for you, which one is HIPAA compliant, encrypted. I know HIPAA has been put to the side, but I still think it's important to really focus on platforms. If this is something you're going to offer, it's better to use something that's HIPAA compliant and encrypted versus FaceTime, because going forward, some of these, you know, free reigning laws are going to be pulled back, and we need to be in a position where we're suddenly not caught off guard with regards to revealing patient information that, you know, because of this time and the changes in laws. So those are some of the things that I've been focusing on at this point.
Great, thank you. And of course, every healthcare system is going to have some of their own policies and procedures around safety. But could you briefly comment before we shift over to Dr. Khan on what types of procedures you've put into place? Are there warm handoffs with crisis hotlines? Are there, you know, are you calling national or county hotlines? What do you do around figuring out where people actually are while they're providing, you know, while you're providing the service, et cetera?
Mm-hmm. So one of the important things is just the consent that we have documented in our notes. So one thing is always know where your patient's located. So for most of our patients at this point in the pandemic, they should be located at home. And we have that information kind of auto input into the notes. But in general, it's important to know where they're located in case of an emergency. Other safety protocols are what happens if there is an emergency in the appointment. Would you call local services, or would you call, you know, if they're, suppose they're in Modesto and you're here in Palo Alto, what are you going to do? So the VA has a system where we actually have an E911 number that we just have to give the patient's location, and they're actually able to locate the emergency services based on where the patient is located. But every county, every system is going to be different with regards to how they're going to manage those issues about where the patient's located. For the most part, for most healthcare systems, the patients are located close enough that you can still call the local 911 services and they'll be able to access them. But I think for people who are delivering services across the state or, you know, across the country even, that's an important consideration to think about.
Great, thank you. Let's shift over to Dr. Khan. So we were talking about kind of some of the pitfalls and things to keep in mind during the transition to telehealth, and some of the strategies that you found for overcoming them. And then also, if you could comment on the safety procedures that you all have put in place as well, that would be great.
Sure. So I do agree with everything that Dr. Mathur mentioned. So safety definitely is a consideration, and I can talk more about that. Other aspects that we consider, so clinician comfort with the technology. So if it's anytime there's a new technology, there's going to be possibly some resistance, there's going to be a learning curve, and just given the current crisis, a lot of folks have had to adopt this so quickly. So that's a potential challenge. Physician education and training, as well as training for our trainees, child psychiatry fellows, postdocs, interns, externs on using this modality. Some of the legal and regulatory considerations that traditionally for decades have been a significant barrier for us. Through our APA and ACAP telepsychiatry committees, we've done a lot of advocacy, especially in the last couple of years, meeting with Congress members. We had a congressional briefing early in February, right before the current crisis, on Medicare and reducing some of the restrictions on the types of practitioners that can be reimbursed through Medicare, the types of sites that the patient has to be located in, so including home as a possible site for treatment, removing the geographic restriction, because we had started seeing some of these changes in the last couple of years. And of course, in the current situation, a lot, as you had mentioned, a lot of these restrictions have been removed, but kind of navigating as an individual practitioner or even part of a hospital system with minute by minute, all the changes we're seeing with licensure, for example. So every state's different. The Federation of State Medical Boards has a list that they update daily of all of the states, and I can send you all of the links. I have one for psychology as well, where they update twice a day, looking state by state. And every state's different in terms of some states saying for the next 60 days or 3 months you can practice in our state without a license. Or they're saying you have to fill this form out or pay a smaller amount than a full license, and you can practice in our state. So I think those are some of the things that we are navigating, working closely with our Office of General Counsel. And then you mentioned the technology. Certainly want to look at technology that's adhering with HIPAA standards. The Office of Civil Rights through HHS has made some changes, as you mentioned, with HIPAA, but if at all possible, we definitely want to be able to use HIPAA adherent technology. For some folks who may not have been doing telemedicine before, they're an individual practitioner now in private practice who may not have that access, because I know a lot of the vendors are not responding because they are so overwhelmed. In that case, some folks may be using things like FaceTime or WhatsApp, but that may not be sustainable past the current situation. And we have a couple of resources for our members through APA and ACAP, which is available to anyone online, and I'll send those links as well. An APA Telepsychiatry Toolkit and an ACAP Telepsychiatry Toolkit. It's a series of about 10 to 15 videos that go through the key clinical, legal, regulatory, ethical, video conferencing, room setup, and other considerations.
Great, thank you. I think we have the APA one on our Tech Hub website, but I'll make sure that we include the ACAP one as well. Those are really valuable resources. So for those of you who are joining the webinar, we are updating the mental health tech website regularly with telepsychiatry, telepsychology resources. So please do have a look at that if you're still trying to find that. And that includes a lot of different resources, both the sort of how-tos as well as some more advanced things like how do you use particular evidence-based psychotherapies over telehealth? How do you make eye contact with your clients? How do you form a good therapeutic alliance? Or what do we know about therapeutic alliance over telehealth? And actually, maybe that's a good next place for us to go. Are there things that you, either or both of you would recommend in terms of, trying to maintain the same type of rapport and quality of interaction with your clients, particularly if they're people that you haven't worked with for a while or that you don't know as well?
Yeah, so I think maintaining the space of the appointment. So you want to make sure that your patients are in a quiet, secure room where others aren't interrupting them. You want to make sure that the connection is good so that they feel like they're actually connecting with you. Something small, but that's actually very important, is looking at the camera as a provider so that the patient feels that you're making eye contact with them. Speaking louder so that patients can hear you, making sure that they can clearly see you, that you're well lit, that you're also in a quiet area, that you can connect with them. I've actually found, so I've been doing telehealth for 5 years now, and almost all of my patients are by telehealth. And I've found that patients actually open up a lot more when they're in a room by themselves with what they feel like is a computer screen, but they feel like they're by themselves. So they're able to share a lot more than they ordinarily would when it's an in-person appointment. So I think those are some of the things that I set up with regards to telehealth. And I've actually had very, very few people who didn't want to continue the telehealth modality. If anything, the barrier is just trying it for the first time. But once they get comfortable with the setup, with the idea that they're speaking to a clinician, the connection is there. If you're a good psychiatrist or a psychologist or therapist, you're going to be able to connect with the patient through the camera as well as you would in person. So for me, I'm biased, but I really think it's a great modality to connect with patients too.
And some kids may actually prefer connecting this way. So children have grown up around technology. They can navigate iPhones better than I can at the age of like 2 or 3. So they're used to it. They're used to connecting with family members using FaceTime or Skype. Adolescents, college students are used to connecting with their friends through video. So seeing their doctor that way wouldn't be that different. They're very open to it. Some folks, for example, if folks have a significant amount of anxiety or trauma history or a child with autism spectrum disorder, I found that they even are more comfortable opening up using this modality. And before I start a session, so especially if it's someone, or actually with anyone, before I start, I'm always very clear with mentioning that I'm in my office, or I am in a very secure space with the door closed. There's no one else in the room with me because they have a limited field of view. So just being very clear with, there's no one else here. If I have headphones on, I'll say, I have these headphones on, no one can hear what we're discussing. And then before we start the session, I'll ask them as well, since I have a limited view of the room that you're in, who else is in the room with you? Is there anyone else that can hear? Is the door closed? So that can be very helpful. And then, like you mentioned, looking at you have to get used to it, but looking at the camera, minimizing that gaze angle. So that's the angle between where the camera is located and where you're looking on screen. Because if that is not minimized, then it's going to look like you're looking down on the other end.
Yeah, that's a great point, and something I noticed just when I'm on webinars and things is there's a sense of I want to look at the face on the screen, and if it's not close to the camera, it doesn't actually look like I'm looking at them. In terms of getting started and maybe kind of delving into the more in-depth therapeutic work, especially, it sounds like that reassurance of privacy is really important. Are there any things that you find that you can do with telepsychiatry or telepsychology that might actually even be advantageous other than people opening up? Are there, for example, opportunities I'm thinking about, like, looking around and seeing what an adolescent's room is like, getting a better sense of what their living environment is, opportunities for exposures or things like that. Can either of you comment on opportunities that maybe we have over telehealth that we don't have in an office.
Sure. So recently I've been doing even more visits than usual, and it is really nice to be able to meet children and families where they are in their naturalistic environment. So I get to meet the pets that we've talked about for a couple of years that I never got to meet. I get to meet siblings. We may have both parents connecting together, which is not always the case when they come in my office. I get, like you said, a view of their room. They may give me a tour of the house. I think that really, really can be helpful. You can get a lot of helpful information that way. Just yesterday, I had a patient, we were going through medications, and mom was able to kind of get the medication. She had the pill bottles there. We were able to go through all of those to make sure that the patient is taking, the medications that we've talked about. So there are definitely benefits to doing that. We're able to do group therapies as well. So for example, DBT, which especially now is so important to reduce travel, to reduce community spread. If you have patients with cystic fibrosis that can really benefit from group therapy, but they can't be within 6 feet of each other, why can't we do it through video? So there's certainly benefits.
Yeah, and I'll
Great.
echo that.
Oh, go ahead. Yeah.
I was going to say, I'll echo that same thought. It's actually really nice to see the setting that they're in, their family members, who's in the house, what the situation is. I have a veteran who I've been trying to encourage mindfulness, take 10 minutes to yourself in peace and quiet and practice that. And for our half-an-hour appointment, we didn't have a minute of, quiet time because there was something or the other going on in the background. He lives in a 1-bedroom place with 3 other people. There's dogs and cats. There's no space for him to do any mindfulness. And I think it was helpful for me to see, where his struggle was coming from and to really put that into perspective with regards to also what recommendations I can make and what would be more applicable to his lifestyle. So I find it great to be able to actually go into their house and into the space that they live in. If we're able to meet family members, it's always beneficial because then I'm also getting a different perspective on how the patient's doing and what their status is from someone that's not the patient themselves.
Great, that's really helpful. We have a question from one of our participants. Can you address the concerns about video bombing on Zoom platforms, which have been kind of coming out lately? And for those of you who don't know what that is, that's essentially people can type in random Zoom numbers, and if there's an active Zoom meeting and there aren't password protections or ways to sign in, people can just end up joining a meeting. So can you speak to that? Has that concern been raised, and what's being done about it in the systems where you are?
So I haven't faced that because our VA system is encrypted. There's no way for somebody else to enter the meeting. But outside of it, for Zoom meetings, my recommendation would be before you start the meeting or at the very start of the meeting, address what's going to happen. If something comes up, if there's a distraction, somebody else who's not authorized to be in the appointment, or whether it's a family member or some person in cyberspace who's coming, that you would end the session, or what would be your next steps. So I think it's very important to address that right at the start of the session to make sure that everybody's on board with the plan, that if you suddenly disconnect, that the patient is aware that that was the plan and that you'll give them a call back or whatever you've discussed in advance. So I think that would be my approach to video bombers or anything else that comes and really disrupts the session.
Yeah, same here. I agree. We're not using Zoom for patient care at NYU Langone. So we have Cisco Jabber, which is a secure end-to-end encryption. We have WebEx as well, which is also end-to-end encrypted. So I haven't had that come up, but I am aware that that's something that as more and more folks are using Zoom and other common platforms, that's going to be a concern.
And I know there were 2 other questions that came up too, so I just want to make sure we don't miss those and we can address them at some point later too.
Yeah, absolutely. And I just want to see if I can very briefly share my screen, because if you can see this Zoom Pro account that we have, if you schedule a meeting, you can have a password that's required, and you could send that to your patient beforehand. Of course, anything you do like that, there's the added potential barrier of your patient not getting the password, not finding it, something like that. But it is one way to protect a lot of people, I think if they're trying to do this Zoom bombing or if they see that it needs a password, they'll move on. So that is one thing that is available through Zoom. We did have some other questions though, and I'd like to move to the question about, let's see, about the research for telepsychiatry versus in-person visits. What research has been done, and what are the findings regarding telepsychiatry versus in-person?
Yeah, so there's significant research that's been done. I can actually send people studies after this appointment or after this meeting as well. But essentially, the studies have shown that it is equivocal with results to, decreased rates of depression compared to in-person appointments. Some interesting studies that I also saw is patients who have schizophrenia or psychoses or other conditions where they're actually worried about technology and things like that. They've actually been just as amenable to telehealth than in-person appointments. So I think the good news is the research is actually there showing that the efficacy of telehealth is equal to in-person appointments, both for psychiatry, but also for therapy, certain types of kind of standardized therapy like CPT and DBT and things that are kind of more manualized. They tend to do better with regards to telehealth, and the results are equivocal to face-to-face visits.
Yeah, and just to add to that, our ACAP committee worked on a clinical update in 2017 where we have a summary of all of the research that's been, or most of the research that's been done, so we can send that out as well. There isn't any absolute contraindication to using telepsychiatry. We can use it across the lifespan for a wide variety of diagnoses. Like you said, the concern that some folks with schizophrenia, could it kind of become part of their symptoms, delusions, if they're using this technology, but what we found is that that hasn't been the case in clinical practice. I've had several patients that I've treated over the years through telepsychiatry, adults with chronic schizophrenia, and these were in upstate, so these were hours away from here. I'd never met them in person, but I was their doctor, and we provide that continuity of care through telemedicine, which some of these communities never had. So before they started treatment with us, they had been seen by 4 or 5 psychiatrists within a 6-month period. So in many ways, telepsychiatry allows us to provide even better care and that continuity of care that just isn't there in many communities.
Great. What are the findings around safety, adverse events, anything like that related to telepsychiatry?
I don't know of specific studies looking into that, but within the VA itself, we haven't had any significant difference with regards to an increase in suicide rates or increases in relapses, things like that, whether it's a telehealth visit or an in-person visit. Again, maybe Dr. Khan knows about broader studies that have really looked into that.
Not specific studies that I'm aware of that have looked at that. In terms of malpractice rates, we haven't found that the malpractice rates are higher necessarily for televisits. So that's another consideration. I know there was a question that had been sent about how do you navigate malpractice. Depending on if you are an individual practitioner who's trying to get started with telemedicine, you would definitely speak with your malpractice provider to make sure that these services are covered just like in-person would at our institution. We have our Office of Legal Counsel who helps navigate that. So for us, as long as we're licensed, or if there's an exception to licensure, we can practice across 50 states, all states and DC, if we are properly licensed or there is an exception. And then with international telemedicine, that can get a little bit complicated, a little bit more complicated. So there may be some situations where we can provide consultation, second opinions, but providing that direct care, then we would have to look at what that country says, whoever is managing the practice of medicine or psychology in that country. We'd have to look at what their licensure is and as well as data privacy laws. For example, if we're providing care in Europe, we would have to consider data privacy laws there, GDPR.
Great, thank you. So another question that's come up is psychiatry has really been a leader in telehealth and was maybe more prepared for this transition than some other services. So how can psychiatrists help other services at their hospital? Would you consider psychiatrists as leaders in the space, or are there others, other fields that we could also be learning from? So both whether and how you all have been helping fields, or there are other, ways that psychiatry could help other fields and other services at their hospital, and also are there other services and fields that we should be looking to?
So like you said, our field lends itself very well to this care. So often at many academic medical centers, hospital systems, psychiatry might be the highest volume service. It's not uncommon. That was true. So before NYU, I was at University of Pittsburgh Medical Center, UPMC. So psychiatry was the leading service there as well. And often we are the first telemedicine contact for medical students. So we can provide that education and training. I co-chair the virtual health clinical work group across NYU. And it's been really helpful. It's where we bring together clinical telemedicine leads across the institution to share best practices, resources. So yeah, it is very common that we are the ones who are going to be doing more telepsych than other specialties. At NYU, and I think at other institutions as well, emergency medicine is also often doing a lot of telemedicine, so virtual urgent care. We have, before the current crisis, our virtual urgent care service was seeing maybe 35 patients a day, and now, last I heard, that was last week, so it's probably even more now. They're up to 1,000 visits a day.
Great, thank you. Any special considerations to take when evaluating patients who might be decompensating or need inpatient admissions through telepsychiatry? What strategies do you use to try to get the patient to come in if necessary?
With regards to the current COVID crisis or pre-COVID?
It's probably good to mention both, because I think some people might stay shifted to this new this new way of doing things even beyond.
So in most cases, I actually like to have whether it's a spouse or a family member or some other support person who is involved in their care. So if the patient is resistant, suppose they need to come into the hospital or come for in-person evaluation, but they're resistant, assuming the patient has agreed for us to involve this other person in their care, I often elicit their help and their support with regards to bringing the patient in and kind of working towards convincing them that this treatment is the right option. Most patients are actually pretty receptive. Generally, we have a good rapport. They're pretty receptive to coming in if they need it. Sometimes you may have to convince them a little bit more, but I think enlisting other resources is helpful. I also enlist other care members on the team. So if they're working with a therapist, within our system, or somebody else, a social worker who they have a connection with, I often add them to the notes or connect with them directly about my concerns with the patient and the need to either come in for an inpatient hospitalization or maybe a partial hospitalization program. And so ordinarily that would be the case. In times of COVID, we're really trying to minimize exposure for patients. So unless they're really holdable, acutely suicidal or homicidal, gravely disabled in some way, then we are encouraging them to stay at home. And my approach right now is to really focus on their care, close management of their symptoms. So really getting all members of the care team on board and involved, especially if they're starting to decompensate, closely monitoring their medications, bumping it up if needed, and also checking in more frequently. So people who ordinarily I'd check in every 6 months, if they're voicing concerns right now or a flare up in their symptoms, now I'm checking in about 4 weeks, and just kind of closely monitoring the situation, because we really are trying to avoid people coming into the ER or to other places unnecessarily, or if we can avoid it.
Yeah, and it would also, absolutely agree with everything you said. It would also depend on how far the patient is from where you are. So similar to in-person, we would do safety assessments regularly throughout our care. And if at some point we think a patient is not appropriate for telemedicine, we want to make sure that we know what the resources are. So if it's someone close to you within the city, it's a little bit easier, or if you have more resources in the city, but let's say our patients in upstate New York who are 5 hours away from me. So before I even start treatment, I do the best that I can to learn as much as I can about their local systems of care. So what is the local crisis number? And it depends if we're providing this care directly into home versus in a clinically supervised setting. So for example, some of our services are in school-based clinics, in day treatment programs. So we have staff on site that can help navigate if there is a safety issue. If we're providing this care into homes, we want to know the local fire department number, police department number, and those numbers may change over time. So definitely want to be mindful of that. And like you said, having collateral is so important. If there are family members involved, significant others that we can engage as we're treatment planning. Right now, in the context of the crisis, Bellevue Hospital, which is affiliated with NYU, we have a partial hospital, which currently they're coming up with innovative ways to be able to provide this care while patients are in home. We have day treatment programs, which have closed in upstate New York. So also working with the social workers to make sure that we have a system in place where we can connect very regularly with families in their homes, whether it's by video or telephone.
Great, thank you very much. And I want to just mention that it looks like Dr. Jeannette Giorgio has joined us. Thank you so much for joining us today. I did a brief introduction of you at the start, but if can you hear me?
Yeah.
Great. Yes, perfect. Okay, so why don't we we've just been sort of talking about some of the challenges and opportunities, and then we've been getting into some sort of more specific questions as we went, but maybe it'd be good for us to have you just briefly say a little bit about how you've been using telehealth, and then I'm going to get into some sort of COVID-specific questions, and we'll keep talking about how to really, address concerns about care in this particular context, but also opportunities and how to really make the most of the telehealth platform. So why don't we let you just kind of say a little bit about how you've been using telehealth in general, and some of the opportunities and ways to overcome pitfalls that you've sort of some of your top suggestions.
Sure. So hi, everyone. I'm Jeannette Giorgio. I'm a psychologist. I work at the VA in Sacramento. I'm on our PTSD clinical team and the team lead there. And then I'm also a cognitive processing therapy consultant and a regional trainer. So as folks may be aware, the VA has done a lot of telehealth. That's a platform that we've been using for quite a while. And so I would say probably in the past two years or so, I've really seen it increase dramatically. And so my caseload, I do trauma work, so primarily cognitive processing therapy, prolonged exposure are the main modalities that I'm using. But I would say at any given time, between 50 to 75% of my caseload is actually telehealth. Because that's really been what folks in our clinic are preferring. And so as we've made that more available and the clinicians have become more comfortable with it, many of our clients actually prefer that modality. And even folks who start off in person, oftentimes because of competing demands on their time or transportation issues or other factors that come in, we end up transitioning to VVC. In the VA, we call it VVC. We end up transitioning to telehealth instead of terminating therapy. So I think that's actually been one of the biggest benefits that I've seen, is the ability to engage people in treatment that otherwise would not be able to come, and then also the ability to retain people in treatment when their life circumstances change and they can't take the 3 hours out of their day to drive down and see me at 1 o'clock on a Tuesday afternoon anymore. So, so I think those have been the biggest benefits. And, for me being able to, again, engage folks whose lives are complicated, who have lots of different competing demands on their time, who know that they need to do the treatment, but have difficulty kind of puzzle piecing it into their schedule. This really just creates so many more opportunities for them to do that. So, yeah.
Great, thank you.
Sure.
I want to ask each of you, these are, you were just talking about things like competing demands. And, this is an issue for people certainly when we're not all sheltering in place, but has really been heightened for a lot of people. The fact that it might be hard to get privacy because they have family members around, maybe there's very little private space where they live, that there are other factors that might be particularly salient right now, like challenges around employment and concerns around that. So I'm wondering if you could each speak to sort of how you've handled these things, as people really are making their own transitions into doing this at home where they might have less privacy, where you can really see that even under the best of circumstances, they have a lot of competing demands and stressors that are maybe even entering the room even more under the current circumstances. So could each of you talk about how you've been addressing these and the types of concerns and things that have been coming up in the current context with COVID-19 being such a looming issue in all of our lives?
I think you've got to do the best you can, as I'll talk about the provider side of it and the patient side of it. Many of us are forced into the situation of telehealth where you're suddenly mandated, or in order for your private practice to survive, you have to do telehealth appointments, and we can't, with the shelter in place, we can't leave home. So give yourself some grace, try to get a quiet space, try to be in a place where there's no distractions, but sometimes our kids run in, or a dog starts barking, or something's going on, and I think you have to deal with it. You're trying your best, and that's all you can do in this situation. Ordinarily, after this is all over, I would say get a designated quiet space that's, HIPAA compliant in different ways, that other people can't listen in on conversations, where there wouldn't be distractions or interruptions, preferably if you can lock the door. But we're in unprecedented times here. Things are going to happen, and I think, do it to the best of your abilities. From the patient side, have that understanding that for them too, they can't always control what's going on in the background. They may try to go to a separate room, but somebody needs them urgently, or a kid wanders in, or a dog starts barking, things like that. And I think letting them know that that's okay, having them do their best. And then again, when we switch back to ordinary circumstances, just setting the parameters for what's appropriate, what's not appropriate, making sure they're dressed, and, basic things are what we're looking for at this point. And I think later on, once we get out of the COVID era, just creating stricter parameters for how we would conduct sessions.
Yeah, and we have much smaller living spaces in San Francisco and New York City, so that's definitely a concern right now. So I have families and children that we see that are getting very creative. So whether it's going into a closet, if it's a walk-in closet, so you have some secure, you have a private area, or if you have a car, they can go into the car, bathroom, if needed. And like I was saying, just being very explicit before you start the session that, because I have a limited field of view, if anyone does come into the room while we're speaking, please let me know. That can be very helpful, because often we're not aware, and then we'll all of a sudden see a family member, or if we hear a family member answering a question. So just being clear with that up front can be helpful.
Yeah, I agree with all of those. And I think, something else that can be helpful, or that I found helpful, is making sure that I and the client and I have a shared understanding of what private means. Sometimes what I think is private, or my expectation for private, is not their expectation. And so similar to what others were talking about, they said, yeah, it's private, it's great, and then, their wife sort of pops into the screen. So I think having that kind of conversation about what does that really mean to have a private space, and how do we do that? And then also a barrier that often comes up for folks, or that has been coming up now in the context of COVID, is, that their family may not be aware that they were in treatment. And so, helping them facilitate a conversation around, okay, you didn't tell your partner or your family that you were in therapy for PTSD. So, now you have these appointments, right, that you have to somehow explain. And so either helping them figure out, what do they want to share with their family to elicit their cooperation and getting that private space, and how much do they want to share with them? And then also helping them figure out how to share that, right, in a way that feels safe and comfortable and is likely to get a supportive response. So I think those are new conversations that are coming up in this context. And then certainly telehealth provides lots of opportunities to be creative in terms of where can you have your sessions and how can you fit this into your life. So yeah, you know, I have lots of folks that will meet with me from their car, you know, so they sit in the driveway or they drive down the street, you know, in front of the park and they do their sessions there. Or, you know, I had a gentleman that was a construction worker, and so he would you know, on his lunch break go hop in his truck, you know, and he just kind of let his boss know, like, hey, I need to take an hour-long lunch, you know. And so there would be lots of construction noise going on in the background, but you know, he was still able to participate. I had another client who was a single mom, also working. And so she was able to fit in telehealth in between kiddo drop-offs. So she would drop off her one daughter, and then her younger daughter would be in the back seat, you know, on her iPad with the headphones, while we were doing the session in the front seat in between when she needed to drop off the second kid. So I think there are sort of endless possibilities to be creative, as long as you have kind of a shared expectation of what that looks like. And then I also want to really echo the comment about being gentle with ourselves, understanding that many of us are facing these same concerns as we're working from home. And so just having a little bit of flexibility and understanding for ourselves that, yeah, if there's a kid screaming in the background or your little one runs in with a question about homework or, you know, something like that, that we just have to be a little bit more understanding, I think, on all sides about those kinds of things right now.
And I think we're so fortunate that we have the technology where we can continue to provide this care to our patients in the context of everything going on, which we otherwise wouldn't have been able to.
Absolutely.
And then certain technology that can make it even easier for us to provide this care. So multi-point video. So if you have a parent at work, if you have a child at home, you could use multi-point video to kind of bring everyone together. So in some ways it enhances the care we can provide.
That's great. You know, it also occurs to me that sometimes we might really see things that we wouldn't otherwise see, sort of like what Dr. Mathur was talking about earlier, when, you know, really understanding why mindfulness wasn't necessarily going to be easy when somebody's got, you know, tons of noise in the background and constant distractions. I'm wondering too about, you know, seeing or hearing or learning things that maybe the patient hadn't even raised as an issue that you can learn about, like hearing the way that their family members talk with them, you know, having a sense of that level of you know, noise or disruption or chaos in the background, you know, things like that, that have presented opportunities for you to get a, you know, better, you know, conceptualization of what's going on and how you raise some of those issues with the folks you work with, or if you.
Yeah, I think it works both ways, where sometimes you're surprised at the level of chaos and dysfunction that's going on, and other times you expected more. And I think it gives us good perspective, especially in the cases where you think it's this very chaotic, stressful situation, and it's not, but it kind of is reflective on how the patient is experiencing that. And I think that allows me to better treat them as a psychiatrist, to really understand, you know, what the situation is at hand, and then also how they're perceiving it, because often those are both not aligned. And I think for me to be able to see both of those, then I can make an educated decision with regards to treatment and what types of, whether it's therapy or medication or a combination of both, or even the approach and the style that I use with the patient. It can often be, you know, changed based on the two worlds that I'm really experiencing from them.
Mm-hmm. And I've found that that sometimes you do get data points that you wouldn't otherwise have, that, again, from a cognitive processing therapy perspective, you know, you can use as evidence against. So, for example, you know, I had a client, one of her big stuck points was, I'm a horrible mother, you know, but whenever her little toddler would come wandering in, you know, she was so gentle and so validating. And so, you know, and so it actually provided these data points for me where, you know, I could talk with her about, well, you know, what about this? And I saw you do this. And so I think sometimes we do get that data that we wouldn't otherwise have, that we can then bring into the therapy, right, and use in a positive way.
And our early childhood service psychologists actually do parent-child interaction therapy in home in some cases. So being able to do that in that naturalistic environment, I think, adds a whole new layer of awesomeness with what we're doing.
Absolutely. And we've had a couple of questions come up specifically about child and elder abuse, and you know, what happens if you become aware of child or elder abuse when you're dealing with something, you know, when you're interacting with people over telehealth. How would you frame situations, and what do you do if you become aware? You know, I mean, are there different and special considerations over telehealth? For example, you might see something you wouldn't have otherwise seen that they haven't disclosed, and what are the obligations and considerations around addressing those situations?
So I haven't had the experience yet, but it would be the same in person if, you know, somebody is smacking their child on telehealth versus smacking them in real life. We're mandated reporters. We would have to report that to CPS or Adult Protective Services. And so the same parameters, honestly, for me, again, I haven't been in that situation yet, but the same parameters for what would happen in person would be, you know, what I would apply to telehealth visits.
I agree. And there is a concern more recently in the context of the current crisis that the rates of domestic violence may be potentially higher, and child abuse rates with everyone at home, stay at home. So that's definitely a concern we need to think about. And like you said, we assess for that just as we would in person. And as mandated reporters, we would do the same thing, whether we're seeing someone through tele or in person.
Mm-hmm. Yeah, I agree. I could see where potentially you would get in a situation where maybe you're seeing something, and I think all of our clients, when we do our informed consent, we include, if you say something that indicates there's a child or an elderly person or a disabled adult in danger, right, we have to report that. But this creates that other condition where maybe they aren't saying something, maybe they aren't intentionally disclosing, right? But it's something sort of, accidentally that you're seeing in the background. And so I think that informed consent is just so important, right? That people know from the outset what our obligations are and the conditions under which that can arise, that it can be, if I see something, right? If there's something that happens that indicates there's someone in danger, whether you intended for that or not, right? I still have the same obligations to report. So, yeah.
Right. So that might actually be something added as you convert to telehealth with an existing patient, to make sure that you include that in the informed consent, that I might see something that you wouldn't have otherwise disclosed to me, and I would be just as obligated to report that as I would if you disclosed it.
Mm-hmm. Yeah.
We have some questions. We've got several, and I'm monitoring them, so I'm planning to get to as many of them as possible. I guess a question that might be helpful to address right now is, are there other forms of technology that we can be integrating into telehealth, either now or in the near future? I mean, obviously we're all, on computers, et cetera, but are there other forms of technology that it might be helpful, or that any of you have integrated that you'd like to speak about?
I think this is really the era of technology now. We've kind of irrevocably changed healthcare and the way we're delivering healthcare. So I think, telehealth, it felt like the future. Telehealth is already here, and very soon it's going to be old news. I think now we have to look into, digital health, whether it's apps. We have a Fitbit that monitors our heart rate. What about something that can help monitor our mental health symptoms, or how much we're moving? If we start to isolate more, if we're starting to eat less, if we're starting to, not shower every day. I think this is the area where technology is really going to start to catch up and really focus in on healthcare, whether it's mental health or otherwise. I think this is the area where there's more development. And up until this point, we've been using a lot of apps. The VA has developed a lot of apps, whether it's PTSD Coach, or we have a CBTI for insomnia app. We use those a lot to help patients track their symptoms, monitor. But I think, now that everyone's doing telehealth, now that people are in their homes, I think we're really going to see an increase in technology that's allowing us to reach our patients in between appointments, which I think has been the biggest barrier in mental health. If I see somebody 3 months from now as a psychiatrist and just doing medications, a lot can happen in 3 months. And it would be really helpful to have some kind of monitoring in between, other than just relying on the patient to call me when their symptoms get worse. So I think this is where we're going to see, I'm hoping, an increase in technology that allows the patients to connect with us and allow us to kind of monitor their care in between appointments.
Yeah, I agree. I think the integration of apps and then certainly some of that like real-time monitoring for folks and being able to get that data more consistently are going to be really helpful. I love that idea of like with parent-child interaction therapy, being able to be in the home and be sort of coaching, you know, via technology, and similarly applied to PTSD treatment. You know, I was thinking about, like, does this open up new opportunities for in vivo exposure and coached exposure and things like that, you know, where they can kind of take me with them, you know, via technology with their cell phone or however we do that. And being able to be, you know, more of a discreet, in the moment type coach. So I think, yeah, there's lots of opportunities and avenues that this opens up as the patients are mobile, the therapists are mobile, and the therapy is mobile. So it's pretty cool.
Yeah, and I know there was a question I see here about assessing patients, which is related on medications with regards to orthostatic blood pressure, Ames exams. So if it's a clinically supervised setting, we may have nurses on site who can help with measuring vitals. If it's in home, then we do have things like Apple Health kits where folks are able to get these measurements. And as we were discussing remote patient monitoring, we can actually feed that data automatically into our electronic medical record. So we have that available at the time of the visit, or I'll just show folks, parents how to check heart rate, and they'll do that in real time during the visit. With an Ames exam, so the abnormal involuntary movement scale, if we want to assess that, so with the right technology, you actually can do it through video. So we have in some of our sites pan tilt zoom cameras, high resolution. So we are able to have someone complete a full exam. If you zoom out, you can have them walk across the room. You can zoom in and you can get very close and assess for tremors. And actually, in some ways, you can get even closer without being intrusive. If I were in person doing that, if I say, like, let me take a look in your mouth, it's a lot easier to get a really good look through video with the right technology. So we actually are able to do the Ames exam through video.
Great. David's asking if you can provide more specifics about the Apple Health kits for.
So I don't have any much more to add, but I know our lung transplant service is using them to monitor vitals regularly across NYU. Other departments are using them pretty commonly.
Great.
We has something called peripherals. So we are able to send iPads to patients who don't have, you know, we also are kind of neglecting to mention the patients that don't have access to technology. We're all very privileged that we're able to access it. Most of our patient population is, but there's a vast, you know, population of patients with, you know, homelessness, poverty issues, financial barriers that don't have access to technology. And so the one good thing that the VA has been able to offer is we can actually send iPads to patients who don't have internet connections, who don't have the, you know, laptop or phone or something that they can video connect with us. And the great option with the iPad is we have something called peripherals, where we can actually attach a stethoscope or a glucometer or a blood pressure cuff, where they can actually take it there. It's, you know, not the same as having it done in office, but it is something, and it gives us an indication as to how their medical health is going too. So I think, you know, we're talking about the resources that we have right now, but I think there's a lot of room for expansion, and I think it's going to happen. There will be a time where, you know, a patient just has to click their watch and suddenly you have their EKG reading done and their, you know, their blood pressure and temperature and things like that. So I think, you know, where we are now is it's important to take these into consideration, but I think this is also an area for us to now look into how do we build on telehealth? How do we make this, you know, an equal force, not just in mental health, but in other medical specialties as well?
And given the current situation where I think at the federal and state level, legislators, policymakers, regulators appreciate that a lot of the children and families we treat can't make it to the clinics that they usually would go to. So for example, in New York State, the Office of Mental Health, and I know a lot of states are doing this, where they're now approving the use of regular telephones. So for families who don't have a smartphone, who may not have access to a camera to be able to do audio video visits, we are able to do telephonic visits, and they are reimbursable right now in the current situation in a lot of states, similar to in-person.
Great, and that actually anticipates something I was going to ask next. For people who don't have access to the more, more advanced technology and do need to use telephone sessions, I'd love to hear, about, or people, that the tech isn't working and you have to switch to phone. I'd love to hear some considerations and thoughts about how to get the most out of phone sessions, and also how you would deal with things like if you're collecting things like PHQ-9s, or you're using something like CBT worksheets. What do you do? How do you handle that over a platform like Zoom or VDC or any of the platforms you're using? And what do you do around the phone? How do you make sure that you can kind of get that information from people?
Yeah, I find the phone to be the most limiting option. You can't see the patient, you can't understand the context of what's going on. You just get, more one-word answers as opposed to the story that we're looking for when we're doing video visits or in-person visits. So I think, I had a patient today who refused a phone visit or a video visit because his wife felt like their house was too dirty and she didn't want to clean it. So they did a phone visit instead. And, it's fine. Everybody has their preference. And I'm not looking at their house, but I think it just kind of goes to show that depending on the scenario, sometimes people do prefer telephone. And it was a much more limited visit, as opposed to a full 30-minute visit where we really get into a lot of his symptoms and other things. It felt much more, concrete. How's your depression? How's your mood? How many hours are you sleeping? It's really hard I find it harder to engage with patients by telephone. That said, I think at a minimum, we can all do risk assessments by phone. And that's what we're looking for, that the patient is safe, that they're stable. I don't think it's the greatest modality to deliver therapy where you really need to engage with the patient, but it's an option. In times like this, I think any connection is better than no connection at all. And I'm forgetting the other parts of the question, but I think, I can't remember the other parts.
No, I know. I have a tendency to ask multi-part questions, so I apologize. And this actually might be something that Dr. Giorgio can talk about as well, because I know you probably had to deal with things like if you're trying to do something like a cognitive behavioral therapy with someone and you're using things like worksheets, and or if you're going through and again getting regular self-report measures from people, how do you handle that, particularly if the technology is maybe not cooperating and you do have to switch to something like a phone?
Mm-hmm. Yeah, I mean, that definitely happens, right? Where the tech just isn't working that day, or like right now, we're offering telephone for folks because we aren't offering face-to-face. And so I do have to say, I myself had a little bit of a negative automatic thought around this, that, I'm not going to be able to introduce the material in the same way. And I've certainly done later stage therapy. So for folks that are fairly well established in the therapy and they're familiar with the worksheets, a telephone session actually has been completely fine, right? Because they know the material, I know the material. And so we're just kind of walking through their answers, doing the Socratic dialogue or the emotion processing, depending on the therapy. And so I'm not having to introduce anything new. Or try to help them understand, again, like a new worksheet or something like that. And so I find for folks that are fairly well established in the therapy that, it's a pretty easy transition. It's fine to just go ahead and do it that way, as long as, again, we're both sort of familiar with what we're looking at and can walk through it together. Like I said, I had that negative automatic thought about earlier stages of therapy when you're introducing things, and I'm a very visual learner, so I like to put things up on whiteboards, or if I'm doing telehealth, I'm screen sharing and I've prepared different documents that have movable pieces so I can kind of replicate that via a shared screen. And what I'm finding is that that's just what it was. It was just a negative automatic thought that actually, people are picking up on the content, and that I am able to explain it without having to rely on the visual. So I think the visual is nice and it helps facilitate instruction, but for many folks, it's not critical, right? That you can still provide some good intervention, even if that piece of it is not available to you in that moment. As far as measures and getting that kind of information back and forth, If you have email capability, I think that is the most helpful, right? So in the VA, we have secure messaging, so we can send things back and forth, so people can, snap a picture of their measure and send it, and I can see it ahead of time. If that's not available, then just, going over it orally. So if they have the measure ahead of time, they've taken the time to complete it. And then at the beginning of the session, we spend a minute or two just kind of running through what are their numbers and comparing that to how it looked at the last session and processing that a little bit. Again, I find that really is not much of a barrier at all, that it's pretty easy to facilitate tracking that data and doing good measurement-based care through these types of modalities.
Great. And Dr. Munoz mentioned here in the comment box that you can use text messaging to get data as well. Particularly, I think if you're using a secure messaging platform, yeah, there could be opportunities even to assign homework, something simple like an ABC worksheet or something, what's the situation, what's the thought, and how did you feel? And they could, even just send you those over text, for example, if they're not able to use an app that you have access to, or something like that. So I think that's a really helpful suggestion too, and people are having to get more and more creative about these things. We had another question about how the homeless population is being reached right now. Have any of you had the experience or had to sort of problem solve around working with folks who are homeless and might not have any private space or very limited access to the technology that they would need for a telehealth session?
So at NYU, one of our hospitals, NYU Brooklyn, we do have telehealth set up in a few of the shelters in Brooklyn. And I think, we do the best that we can to make sure that it's a secure space, but they are able to get that care at the shelter.
Great, that's really fantastic. Shifting gears for a second, we had another question. Dr. Mathur, you had mentioned that you're also very interested in prevention, and we had a question about how you're dealing with prevention and handling preventive interventions over telehealth.
Yeah, and I think that's what I think we all need to look towards. I wish I had the answer to that, and I think it was Dr. Munoz's question that I wanted to answer. But I think that's what we need to all look towards. That's the billion-dollar question for healthcare in general, not just mental health. How do we can prevent these illnesses? We'll save billions of dollars in hospitalizations and healthcare bills, medical bills, and a lot of morbidity and mortality. And I think the key is, what my thought is that interventions in between appointments. So, whether it's a week long, you're meeting weekly for therapy appointments, or like I said, I meet my patients every 3 months, some way to be able to remotely track patients so that during their areas of decompensation or their difficult times, that we're able to connect with them, whether it's as a provider or if you're working for a healthcare institution, kind of reaching out to them and checking in. Are you okay? Are you doing okay? Would it be helpful to, set up a session or a quick phone call with your psychiatrist? And I think that's really what we need to, the model of care that we need to look towards right now with regards to prevention, implementing healthy habits, good sleep schedules, really promoting this. So I know for I have Blue Cross and Blue Shield. If I sync up my Fitbit or my Apple Watch, I get a $50, credit for something. If they had the same thing for mental health care, I think that's something that we need to really incentivize, is that mental health care is just as important as the number of steps that you're walking every day. And if there's a way that we can help track that, I think that's what we're really lacking in the field right now. And that's the area that we should be focusing on, is this kind of remote monitoring of patients, obviously with their consent, so that we are able to reach out to them in their times of need, or in the times so that we can prevent a hospitalization or a suicide attempt, or even just somebody spiraling back into addiction problems.
And other examples.
That's great, thanks. Oh, go ahead, please.
Sorry. So our pediatric diabetes clinic, our psychologists at the clinic are also using telehealth to regularly follow up with patients. We have dietitians as well, nutritionists who are regularly tracking diet, blood sugar levels, and all of that information can be so helpful for us to determine, as for the endocrinologist, do we need to make medication changes? Is it critical where we want to have a patient come in for a visit? So it's really helpful from a prevention standpoint.
That's great, thanks. And speaking, this really kind of opens up the question of, this is going to be something of a shift I imagine some people are going to return to face-to-face care when this is all over, but this really might have, be the thing that's pushing the field towards more telehealth. And so what are the opportunities to really innovate instead of just converting care to a new platform and treating it like, the same type of care that we were doing face-to-face? You've already spoken to this in some ways, but what are the other opportunities to really kind of move beyond and exploit the capabilities of the technology that we have and that we'll have in the near future?
So I think when we think of telemedicine, most people would consider that to be that audio video providing direct clinical care, but the technology expands so much more beyond that. So rather than just thinking of it as just clinical care, there's also consultation, so not taking on direct care, but providing second opinions or consultations to another practitioner. There's also education. So we can use, there's the Project Echo model, for example, extension for community healthcare outcomes, where you can connect using multi-point video, similar to what we're doing now, to be able to connect with multiple sites for de-identified case presentations and didactics. So that way, rather than that limiting yourself to that one-to-one care, you can now expand access. So rather than, like, let's say I'm treating 50 folks at a clinic, but if we have a model where we're providing education to 10 different practices, then that extends our reach even further. So I think education is definitely another venue where we can utilize this technology. And then supervision as well, where we can supervise our trainees who are in multiple locations without having to travel.
I think one thing we're looking towards in different healthcare systems is an increase in collaborative care. And so suppose, I have a patient, I'm in session with them, and they reveal something that I think it would be helpful for the therapist to hear. So ordinarily, in-person appointments, you see them, or even by telehealth, just one way, I see them and the session, I convey the message to the therapist, who then creates an appointment with that patient and follows up. But there's, we're missing information. It's a little bit of whisper down the alley. Whereas, I envision a system where I can just message the therapist, are you free right now? I'm seeing Mr. Smith. Can you hop into our video conference? He just shared this information with me. And then we can work as a trio to really problem solve. And it doesn't just have to be with mental health. Suppose they have a medical issue and I can bring in their medical provider into the video conference and we can all really brainstorm together. I think that's the model of care that we're looking towards, because medical problems are all interrelated with mental health problems. It's all, one can't operate without the other. And so I think by being, more open to telehealth, we're really increasing our opportunities for collaboration with other specialties.
Yeah, and just to add on to that with therapy, I think this idea of that a therapist doesn't have to just exist inside of the therapy office, right? I have a lot of clients who say to me, like, you're the voice in my head. I hear what you're saying when I'm over here, and the idea that I could potentially actually be that voice in their head when they're dealing with these situations, and being able to provide that live coaching, that live feedback. I think that's an opportunity that hasn't necessarily been there before. And so just, this idea that we don't have to be restricted to the office or to that frame of interaction, right? That we can be more interactive and more involved and helping them in these real life situations as they come up, I think is very exciting.
Great. What expectations do you all set, and has it changed for communication between sessions? Now that people are, not coming into therapy, I'm wondering if you've seen any changes or expectations of blurred boundaries with, communication between sessions, and how you handle those types of things, particularly if you're using something like messaging to, get some of the therapy homework or to ask people to send you information in advance. Have you seen anything like that, and what expectations do you set around communication between sessions? Are there differences?
In my case, I want them to communicate with me. I give them, direct office access. They have access to my phone extension through our VA secure messaging system. They're able to message me anytime. So I want them to reach out to me. I think the tendency is that, even the veterans that I'm calling, well, we don't want to bother you, doctor, but we've been having worsening symptoms. And so I've actually seen that people are withdrawing a little bit more or more hesitant to reach out because there's also this looming pandemic. You know, they know that medical resources are short supply and everybody is stressed, so they don't want to be a bother on the system. And that's actually my concern. And so I try to stress to them and really let all my patients know that I'm very accessible to you and to any issues that are going on right now. And I'm not sure if you guys faced anything different right now.
Yeah, so we have a patient portal through our electronic medical record, so a secure way for families to communicate with us regularly, similar to before our current situation. And luckily in our department, we had all of our faculty and trainees already set up to do the EMR integrated video visits, so that helped us tremendously. So just last week, 9 of all the visits that we had scheduled in advance that were going to be in person, we were able to convert 93% of them to video. We were very fortunate, because I know with a lot of other specialties or a lot of other folks that didn't have that infrastructure already in place, they're canceling 50% of appointments. So there's more of that, what are we going to do right now if we can't have those visits? So we've been lucky, and that patient portal has been very helpful.
Mm-hmm. Yeah, I think it's been interesting in the VA because as you were mentioning, you know, we have the secure messaging, we have, you know, phone, and we have the front desk. And so there are definitely, you know, ways for folks to access us. But in this age of COVID, you know, all of that still felt a little bit kind of behind the wall to me in terms of, you know, with secure messaging, there are strict rules. If people don't follow them, you know, they're not allowed access to that. And same thing with voicemail, you know, on my message, it says, if you're in crisis, you know, do this, that, and the other, don't leave a message for me here. So it still felt very protected in kind of VA land. And now with the advent of COVID and all of this coming around and loosening of HIPAA, you know, we've been getting directives from the VA that, you know, okay, if the telehealth platform isn't working, you can use Zoom, you can use Google Hangouts, you can do a Facebook Messenger meeting. You know, and, you know, we're calling now, those of us that are teleworking, we're calling from home. And so, you know, using our personal cell phones to call folks and, you know, using Doximity Dialer or *67 or some of those kinds of things. And so it has felt to me like this real expansion in terms of my being sort of out in the world as a therapist. And so thinking about, you know, those different platforms and, you know, for example, if I decided I wanted to do Facebook Messenger, does that now make me sort of discoverable to this person on Facebook? And are they going to expect to have, you know, unfettered access to me 24 hours a day that they can message whenever they want? You know, do I now have to create sort of a professional Facebook profile? Same thing with Gmail, you know, all of a sudden I had to create a new Gmail account so that when I'm sending these Zoom invites, it's coming from an email that is not my personal email, and then setting expectations around that. You know, what is my obligation now if this person has a way to contact me via email that doesn't have that strict, you know, setup and format and informed consent and all the stuff that the VA has sort of done for me. So I think it's brought up a lot of questions for me about, you know, what are my limits and obligations, and how do I make sure that folks are aware of those, and what kinds of boundaries do I need to be maintaining, and trying to stay a step ahead of all of that as these things are really dramatically changing. And it has very much been in the back of my mind in terms of, you know, if this becomes the new normal for, you know, 4 to 6 months, what of that can eventually start to be rolled back? And again, what expectation are my clients going to have from this point moving forward? So yeah, I think it's brought up a lot of things that are sort of different from the norm. And is it going to become the new norm?
Right, exactly. And, you know, so there probably are considerations around, for example, if you have a full day of telehealth sessions, and you've got an email that clients can be sending things to you on, what are the expectations about turnaround time and getting back to them? You know, the same things like when they leave a voicemail in your office over the weekend, for example, but now you've got, you know, there's this expectation that people might check their emails all the time. And so, you know, what do you tell them about, you know, the level of urgency of their messages, et cetera, just additional considerations perhaps. And we did have some questions about, you know, right now there are fewer restrictions. These are going to be things that are going to be rolled back. But those of you particularly who have been sort of tuned into some of the policy issues or hearing things in your clinics and programs, what are the things that you think might not be rolled back? Or what do you think are maybe some of the restrictions that might change? For example, practice across state lines, the use of more and different platforms. Are there things that you think we might not go back to after we've all made this transition?
Yeah, I think even before this crisis, policymakers, legislators were appreciating the benefits of telemedicine to be able to provide quality care efficiently. So we were starting to see changes in the last couple of years, but it is so interesting to see all of the things that the telemedicine community has been advocating for like 20 years just drop one by one, minute by minute within like 3 weeks or a month. So I think what's going to be really important is for us to be mindful of, as everyone is trying to set this up as quickly as possible, take a little bit of time to think about what data you'll be collecting, because that's going to definitely help us make the case to keep some of these changes that are appropriate past this crisis. So before our current situation, the Congressional Budget Office was scoring telehealth bills very low. They were assigning low scores, and so those bills were not going through. And their reasoning was that you as a telemedicine community are not giving us data, outcomes data. So now that we have the global buy-in, not just national, we definitely want to think about that, because that's what's going to help us maintain some of the changes. Like licensure, we had the Interstate Medical Licensure Compact before, which was 29 states and DC were part of that. You would still have to be licensed for physicians in each of those states. You would still have to pay the same full licensure fee and an additional administrative fee. I know you guys are at the VA, so a little different for you. It's federal land as long as you're licensed in one state, not a concern. But for folks, especially right now where we have, or in our practice where we have folks going off to college, moving away for work, all of a sudden a person that we've been treating for, let's say 8 years, 10 years, we can't treat because they moved unless we're licensed. So hopefully we'll see some movement there. There's the e-nurse licensure compact for RNs and vocational nurses, LPNs, that unlike the interstate medical licensure compact, you don't have to be licensed in every state. So as long as you're licensed in one, you can practice in the other states. So it's a little bit different, probably works a little bit better than what we had for medicine. With psychology, there's PsyPact. I believe in the last I checked, there were about 8 or 10 states that were part of that. Now there are a lot of exceptions, and I'll send you guys the links of state by state what the exceptions are currently. But I'm hoping that we can continue to do advocacy there, where hopefully licensure will be less of an issue moving forward. And then reimbursement. So Medicare has made a lot of changes. CMS recently removing geographic restrictions, allowing Medicare beneficiaries to get care in home because that for many, many years that was not an option other than end-stage renal dialysis patients, which was also very recent. But now that that's removed, I think hopefully a change like that will persist. And then once Medicare makes changes and private payers and Medicaid, state Medicaid plans often follow suit. So that's something we're working on right now actively. For a lot of our patients with commercial insurances, we don't have the same exceptions necessarily that Medicare is making right now. So there's a lot of advocacy that we need to do, that we're doing, but we definitely need to do more of to make sure that we can continue to provide this care and get reimbursed for it.
Absolutely, and it's a lot for a provider to keep track of. How is this patient's care being reimbursed or paid for? So can I use the phone with them or not, for example, is probably just another complication. Other comments on policy shifts that we might see as a result of this?
Quite honestly, I think there's going to be a rollback with regards to just making sure things are encrypted. Zoom very soon will be end-to-end encryption, mark my words, given how the increase that we've been having in the last couple of weeks. But I think these changes are here to stay. I think there may be some tweaking of them, but whether it's interstate licensure Once insurance companies start paying for telehealth visits, then they're not going to change, because their whole base of patients is going to be used to telehealth visits. And if they're suddenly not covered in 6 months, you better believe all these patients are going to complain, or the institutions will complain to the insurance companies. So I do see these changes as being long lasting, maybe not to the extent that they are right now, but of everything that's been passed so far, I can't think of anything that's going to be kind of going back to square one the way it was, 1 or 2 months ago.
I hope you're right.
Oh, fingers crossed.
Question about both the challenges that are coming up that are sort of specific to COVID-19 and the current sort of shelter-in-place restrictions, but also, unexpected silver linings or positives. What have you all seen in your practices?
Go ahead.
Yeah, I was just going to say, in therapy, I think the one of the biggest challenges has just been the general increase in stress, right? And so in treating PTSD, when general stress goes up, symptoms of PTSD also go up, right? And so for a lot of my clients, it's been about sort of figuring out, what is just sort of normal, natural stress that you are sharing with everybody else right now. Everyone in the world is experiencing this stress, versus what are the things that maybe your PTSD is contributing to this, that we do want to try to use the therapy tools to apply or to address. So I think that's been one challenge, is just, helping folks understand that nobody's going to feel calm right now, right? That some anxiety and stress is normative. And helping them maintain the focus on the symptoms that brought them into therapy, and addressing those as they get aggravated by the current situation. I think in terms of silver lining, I've had a lot of veterans where, they were working on things like going out in public, and they were fighting me tooth and nail. And now that they aren't able to, they're recognizing the progress that they had made on that, and the value that had of being able to go out and be in crowded places and connect with other people. And so I think in some ways their motivation to get back to that is greater than it was, and is more intrinsic than maybe it was when we started. And then the creativity, the ability to focus on interpersonal connection in different ways. So if a person is working on being around other people and they don't have access to crowded spaces, shifting that to, well, let's work on increasing the intimacy and the relationships that you do have. So, for example, I have a veteran who's working, on a sense of helplessness, giving others control. So his homework is, give your son an hour of your day and you have to do whatever it is that he wants to do. Right. And so, that is working on his sense of helplessness, but it's also really strengthening his family relationship. And so I think it's forced me as a therapist, and also my clients, to really focus more on the meaning of those relationships, not just necessarily having somebody close to your body, but having them close to your heart. So it's created some really nice opportunities to expand the focus of the treatment.
Great, thank you. We had a question about supervision and what you all have had to do around, shifting to a supervision of residents, practicum students, interns. How have you adapted training and supervision in the current situation?
So it depends on the setting. For us, we have a telepsychiatry clinic, and we have 20 child psychiatry fellows total, and half of them do a year-long telepsych clinic in upstate New York. So we have well, at least we did until recently, physical telepsych clinics in our practice. So initially I'll sit in with them on visits or as needed for evaluations, where they'll get that direct feedback. Over time, it may be similar to in-person, where I may not always be in the room with them, but they'll staff the case. We just launched telemedicine to our pediatric inpatient medical units just last week. So we have, basically it's a 70-inch screen in their individual patient rooms, and there is multi-point video capability on there. So we'll have an attending and a fellow connecting at the same time to see the patient. So we are able to assess. We can do it with WebEx, which is another modality that we're using in some clinics. We can do multi-point video where I can observe while a fellow does an assessment, and it's less intrusive actually than me being in the room in some cases. So we are definitely using it for supervision. And like we're doing today, we can bring together multiple institutions too for teaching supervision with this technology.
So I'm operating similarly. I oversee the telepsychiatry clinic for residents, Stanford psychiatry residents, as well as medical students and PA students. The med students and PA students are kind of pulled out of the rotations right now, but for the psychiatry residents, we have them working remote, and they're already used to telehealth. So for them, it's not an issue, but similar to what you were saying, Shabana, we actually just integrate. I come into the appointment halfway through, the resident is able to present, the patient, is usually familiar with me because I've been working with them for years, and we're able to have kind of a similar setup to this, or they staff with me afterwards if it's a patient that I've seen in the past and I'm familiar with, or somebody who's stable. But we have options, either way, that either I can join the appointment by video conferencing, or I can just staff it with them afterwards.
Yeah, I would echo, we're doing the same where, folks can pop into sessions that the trainee is running. And again, in a much less intrusive way, I think, than it is when you're actually in person. So that's been an advantage. And then with some of the loosening of expectations around actually being on site at the same site as your trainee, like that's been helpful in terms of, if the clinician, if the supervisor is teleworking from home, the trainee is teleworking from home, being able to meet up in a format like this and be able to provide supervision in that way. So yeah, it hasn't really been much of a barrier. Actually, I think in some ways it's been a benefit.
Great. And can you speak to any emergency procedures? If you're not down the hall, do you use something like texting, or how would someone alert you if they were, dealing with a clinical emergency when you hadn't popped in? What are sort of the plans and backup plans for that sort of thing with your supervisor?
I think it would be similar. So for those of us at VA, we can get online to our instant messaging program. So, it would be sending a message that way, sending a text message. I think, the most important thing is sort of knowing where the client is at. So really kind of drilling that into folks, that they know the location of their client and where they are, and then can quickly communicate that to the supervisor, and then problem solving from there. If, again, now it's a situation where I need to hop in and assist with evaluation, or whether I just need to be, available via text message to kind of guide them through the process of evaluation and figuring out what needs to happen. Which is not, again, actually all that different from when I'm on site.
Great, absolutely, thank you.
Mm-hmm.
Another question that's I think really important is, all of us as providers have been dealing with this transition while also dealing with a lot of the same things, although fortunately maybe not quite as many stressors in some situations as many of our patients. But we all had to convert to telehealth and figure out how to be homeschool teachers and deal with the privacy and changes in our work routines and habits, and not seeing loved ones, and maybe worrying about loved ones that were far away, and so many other things. So so that's been an added thing as we've needed to sort of be or felt a need, I think, to be stable and sort of a source for our own clients who are dealing with these stressors as well as everything else going on. So what have you found has been helpful in terms of self-care, especially now that home and work are even less separate in some ways? How have you all kind of taken care of yourselves in these times?
It's been hard, quite honestly. I'd love to hear other people's ideas, because I think it's very hard to separate home and work and everything else that's going on. I have friends and family who are frontline medical workers, concerns for them, concerns for my family that's older or not located where I am, and not being able to see them, on top of converting our entire system to telehealth. So I think it's been really hard. I think really trying hard to disconnect from everything that's going on. for me, creating a separate space for my appointments and where I do my work, and then a separate space for where I'm able to fully interact with my family and my son and my husband and play with my dog, take breaks where I'm able to kind of go outside for walks and still maintain my social distancing. And I think really, really trying hard to disconnect from everything. And I make it a point that I try not to, watch the news or follow social media updates. It's important to be aware, but I found that I was getting, hyper aware, and everything was really stressful for me. And I'd go to bed, stressed. I'd wake up stressed. I'd go into work stressed, and you get stressed from hearing everything. So I think really setting aside discrete periods where you're not going to log online, where you're not going to think about work, where you're really going to focus on what's going on for you at home and for yourself.
Absolutely. I would echo all of that, just the importance of maintaining the boundary, right, between work and home, and realizing that that's going to look very different. And then also keeping up with those self-care routines in the best way that you can, given some of the limitations. I think for me, just really being a lot more flexible, and realizing, with the VA, we've had network issues, we've had connectivity issues, VVC is down, you can't make the appointments. And so just sort of realizing that, my typical 7 to 3:30 tour, it's not going to look like that, that I may have to log on at 10 o'clock at night because that's when the system has bandwidth. And so, being just a lot more flexible in terms of when I'm doing my work and how to best do that. And I think just being so much more forgiving of myself and recognizing that these roles are going to blur, that if I'm a solo parent / full-time worker / now homeschool educator, that they're not going to be clearly delineated when they're all happening at the same time. And so if a kiddo pops into a session, when I first started this, I was horrified at that thought. And I had all of these really strict rules with my kids about what would happen. And just having to realize that, a lot of that you just have to let go, that, things are chaotic in the world, things are going to be chaotic here. Some of that chaos is going to bleed into the work, and, just kind of letting that be okay for now.
Yeah, I think that uncertainty is, certainly impacting us all. The other thing we're thinking through is for our frontline healthcare workers, essential workers, what kind of support we can provide for them or have available if needed, not just for them, but their children and their families as well.
Mm-hmm.
Absolutely. Thank you all so much. This has really been wonderful. I think we've been able to get through, I hope we've gotten through all the questions that people submitted either during this time or in advance. If not, please do enter your questions in the chat before we wind down. But I do want to share a couple of things that might be really useful to folks. I'm going to share my screen here for a second. Always super risky. Let's see what's on here. But I want to share the Stanford Mental Health Tech website. We have been updating with telehealth resources, including things like the American Psychiatric and American Psychological Association resources, toolkits, continuing education series, tips and advice. And we're updating this pretty regularly. We've included things like research and case studies. And so we'll continue to update this, and this might be really helpful. The other thing is that for Stanford providers, the Yoga X program has noon on Thursday yoga. The information, I think, has been sent out to the community, and you can join from home. You can have a yoga class if you've got that time at lunch. I know that at the VA Palo Alto, our wonderful yoga teacher has also moved to online classes, not necessarily at the times that we had been doing them, but she does have some. So for folks that are needing something other than a walk or something like that, when they've got some time, some things like that are available. I've seen great opportunities for, people can join brief mindfulness calls and things like that. So for people who are looking for just small breaks or ways to have some sort of physical opportunity and self-care, physical activities and self-care, those are some things that are out there. So With that, I want to really thank all of our panelists for taking time at the very end of a busy day to spend more time online to share some of their wisdom and some of their practical tips and what they've learned with all of us. This has really been just extremely helpful. And so I'll just ask if any of you have anything that you had hoped to say that we didn't quite get a chance to cover before we wind down.
I think I covered everything, but if anybody wants to email me, feel free to reach out with any additional questions.
Yeah, same.
That my department is having a cocktail hour tonight, so hopefully I'll get to join that for a little bit through Zoom.
That's great. Yeah, I've been hearing of more places doing that. I think we had an hour of happiness recently at Stanford as well. So thanks so much to all of you. I'm going to let everybody wind down, have dinner, spend some time with their kids or their family members or their pets or doing yoga or whatever it is that you'd like to do next to unwind. But thanks so much for being with us today. And thanks to all of you who joined for adding these questions. This has been just extremely valuable for all of us, and I appreciate it so much. So thanks very much, everybody, and take good care.
Thank you.
Thank you.